little bit of a low bandwidth, so that's why I don't have my video on. But if you're able to hear me good, if you cannot, then there's going to be a recording available of this session as well. What I really wanted to do was to go through quickly the material from this week, and I do realize that this is not as ideal for question and answer format if the bandwidth is low, but let's do the best we can. So this week we have really the biggest thing that we are moving to a new chapter, and you still have time to work on your exam 2, your practical 2. I realize some students have had issues with finding time to do those. If that was one of your messages, I will definitely get back to you and give an extension for those. What matters to me is that you get a fair chance to get those done. So if you can't do it tonight, just right now, don't worry. There will be further time that I'm very, very happy to grant for those. Like you see on the big screen, I'm sure that you realize since you're joining me on this session that we don't have our traditional Wednesday session. So we had on Monday a morning and evening session, and now on Tuesday we're doing an afternoon session. And I'm trying to keep this fairly quick, just simply because of the limited bandwidth, and so that you get a move on. And I'm actually on the road as well. We're going to have a quick look of also this week's module, the assignments. There's a little bit of nothing too much to worry, just 2 labs. So I just want to remind you that there's actually 2 of those to do. And then we'll spend the majority of the time on the respiratory system, looking the key points of that. And of course, there's then going to be the same reminders that I seem to have every time, that if you're missing or need to retake assignments and how the tutoring works and some question and answer. I think that we can still make the question and answer work even if we do it without a picture for the limited bandwidth. So I think that this is probably a little bit of a redundant slide. I'm using the same slides from each session to another. So that's why I have it mentioned also here. So we're doing the last of this week's review sessions now at 5 o'clock on Tuesday. But remember that from next week onwards, we're returning back to the normal. So we're doing them on Wednesdays in the morning at 10 o'clock and in the evening at 8 o'clock. I'm always happy to set other times for other meetings as well, if that's something that helps you. So don't hesitate to let me know. The exam 2 and practical 2, they were due by the end of the day today, but I do realize that some students have had a little bit of a hard time finding the time for that, or there's been other things going on. So if you cannot make it, I'm happy to work with you also if needed. And I'll just put a note here. For me, what's important is that you get a chance to do all the assignments and all the assessment components that count towards your grade. So that's the reason why I'm always trying to be very, very flexible about the due dates. So all you need to do is reach out to me. I realize that I've got a few messages now that are kind of on the hold, waiting for me to tackle those, but I'll get to them tonight. This week's assignments, we really don't have anything too much of a new that you wouldn't have seen before. We have the typical Learn Smart, which was you read the textbook and it asks questions of that. And if you don't know an answer, it even links you to that question where it's covered in the textbook. We have our typical quiz. And then we have the practice anatomy, which is from those lecture videos by Dr. Greer, and then questions regarding those. The big thing to note in terms of this week's content, all of that is familiar, but do remember or do note that this week we have actually 2 labs to complete. Both of them are on the Macro Hill, so on the Connect platform. So you'll just take them there. I checked through them and they should be fairly doable and they should run without any hiccups. It should be easy to access those. So just notice that there's going to be 2 of those. Sometimes students work through the material and they think that they've already done the lab when in these modules where we have 2 labs. So just a reminder of that. You'll find the 2 labs like before on the learning management system. So I'm just wanting to again point out that do both of them because each one is worth of 5 points. So you actually have 5 more points than normally available on this week's module. And like I said, all of that is available at the publisher's online platform, and they will all link to the Canvas. So it should be easy to access them through Canvas. We're going to go through the respiratory system as the next thing. And let me just open up a PowerPoint for that system. And we'll have a look through that. So this system is really, I think that you'll find that it is a little bit easier than what we've been doing so far. And the reason why it becomes easier for many students, at least they feel, is that we have, let me see, how can I put this down? We have less material to cover on these. I find that these become quickly of the chapters as we're moving ahead, where there's not quite as much to cover. And because I have already recorded these videos, there's gonna be my my face at the bottom corner, so don't mind about that, and we'll just work through the key points. Really what I wanted to show here is that all these systems are linked, and you remember when we talked about the blood and cardiovascular system, how the function of the blood was to transport gases. Well, now we're focusing on the gas exchange here. So this is where it becomes especially relevant for us, that there's these overlaps between the systems. I talk a little bit about first response concepts of securing the airway, making sure that there's no bleeding, checking for breathing, things like that. But that's not really the biggest take-home message. What I want us to notice on this slide that we're dealing with oxygen and carbon dioxide. And why are we dealing with oxygen? Well, that of course goes for our cellular respiration. So we're using sugar and oxygen to produce energy. And as a byproduct, we're left with the carbon dioxide and water. So that's the big reason why respiratory system is going to be so important for us and why we're spending time at this point, of course, looking at it. So the function is really going to be to supply us oxygen and get rid of the carbon dioxide where it's not needed. And there's a lot of other non-respiratory functions that you'll notice as well. So I won't spend time on those on this review session, but you'll find them on the full lectures. Respiratory system, these are the parts that we're going to be looking at. We'll look at the nose nasal cavity, sinuses that are within the skull, and then go through the pharynx, larynx, trachea, bronchi, and branches of bronchial tree, and then have a look of the lungs and alveoli. There's different ways of dividing the respiratory tree, and that division depends a little bit on the textbook that you're using. So where the upper respiratory tract ends and lower starts, that's not really crucial in my mind. What's more important for me is that you're able to notice all these parts and know a little bit about all these parts. So we're going to start with the nose and nasal cavity, and really normally the breathing happens through nose. It's only at the time when we need extra oxygen when we recruit also the oral cavity for breathing. And there's a reason why we normally prefer to breathe through nose. And that becomes that air comes through the nostrils. And the first filtering of the air happens there with the hair that we have on the nostrils. That should get rid of the first particles that we don't want to take in. The second place where we're getting rid of particles in the air that we're breathing happens at the mucous membranes of the nasal cavity. So within the nasal cavity, we have a lot of mucus. This was the sticky stuff on the surface of these cavities. And this is produced by, of course, goblet cells. And we've mentioned them before. And there you can actually see even microscopic images that have been beautifully positioned to show the goblet cells right at the outermost layer of this picture. So goblet cells produce the mucus, and mucus serves many important functions that we have for the nasal cavity. The big functions are also assisted by these protrusions that come out from the lateral nasal cavity. They three protrusions on each side that extend towards the midline. These are known as conchi. So we have superior, middle, and inferior conchi. And their function really is to generate turbulence within the nasal cavity, in addition to increasing the surface area of the nasal cavity mucous membrane. And what we'll notice, I'm also listing here nasal septum, which is this midline that separates the right and left nostril, and then the nasal cavity going further a little bit there. What we'll notice really is that all of our anatomical textbooks show all of these structures very symmetrical, very beautiful, but most of the time in real life, they are fairly irregular. Of course, at the bottom, the nasal cavity is defined by our hard palate and soft palate, and soft palate ended up with the uvula at the very back. Really, if we think of the function of the nasal cavity, and I just wonder if I have a separate slide about that, and I do think that I have it coming. So we'll talk about the functions of the nasal cavity a little more. But first, I want to show you the term sinuses. So term sinus is familiar to us as cavities within the various organs or anatomical terminology in general. So paranasal sinuses are these cavities within the skull. Within the skull bone. So there's empty spots there, and we'll have a look of what they are and why we have them. So the first one that you'll notice is named again, based on the bone where it's located above the eye sockets on both sides are frontal sinuses. Within the maxillary bone, just below the eye sockets, are maxillary sinuses. Sphenoid sinus is located further back into the skull, so that's easier to see from the side view within the sphenoid bone. And then we have something called ethmoid labyrinth. Some call those ethmoid sinuses because that's a group of interconnected sinuses. I really describe it rather as a labyrinth. What is the function of the paranasal sinuses? It's a little bit debated. We have some understanding, but some is still unfolding for us. So first of all, that we all tend to generally agree with is that they reduce the weight of the skull. If skull was solid bone, that would be rather heavy for our neck muscles to carry. So by taking gaps within there, we're reducing the weight. The other function that is accepted that paranasal sinuses play a role within our voice formation, so voice resonance. This third one is a bit debated, but it has been proposed that similar as our car's front is designed to collapse when in a accident where we need to actually quickly absorb a lot of energy so that the passenger or driver doesn't get injured. Similarly, these paranasal sinuses would collapse when we hit our face first to the ground and absorb some of that shock. That's debatable. You can form your own view whether you agree with that or not. And we are finding more and more that paranasal sinuses play a role also within the immune system. Here's a clinical example. So paranasal sinuses can get inflamed. So you might have sinusitis. On this picture, you see on the left side of the patient, the sinus fully filled with a liquid material. If it's empty, it would show up as black. So we're still learning more about their role in the immune system, but that's to give you an idea that there can be an inflammation. So let's go back and look a little more about our nasal cavity. We can also see a small hole to the posterior end of the nasal cavity on the lateral wall on both sides. And this is the opening of the auditory tube, so connection to our ear. So if you ever traveled by the plane or driven over mountains, you'll notice that your ears might get blocked. Well, the idea of swallowing, keeping your mouth open, chewing gum, or having a hard mint candy or something like that that causes you to produce saliva and swallow is connected to this, that we're able to reduce that pressure that your ear is subjected to through having this opening that comes all the way to the nasal and oral cavity, since these are connected. Let's have a look of what are the functions of this entire area. So nasal cavity nose, there's three important functions. So first of all, if we haven't caught all the trash that we want to filter from the air, this nasal cavity allows us to trap anything that shouldn't be on the air that we're breathing in by filtering it. This mucous membrane is very sticky and catches any particles there. In addition, there's a lot of blood circulation to this area, so a lot of warmth on the wall, so we are heating up the air that enters to our respiratory system. You can think of what happens when you breathe on a cold winter day, a lot of cold air into your lungs through the mouth. Well, you get cough, and that's because your nasal cavity wasn't there recruited to warm up this air. Same goes for the moistening the air that we're breathing in. So again, if you think breathing in dry air, you get coughing going on. So we want to do all these three functions, and our nasal cavity assists us to do all these three functions to the air that we're breathing further down to the respiratory tree. Well, now we're going to continue our journey looking at the structures of the respiratory tract. We have already covered the nose, nasal cavity, and paranasal sinuses. So it's time to look at pharynx. So what do we know about pharynx? Pharynx actually has skeletal muscle there. And pharynx is divided into three regions. Most superiorly, nasopharynx. So that's the area located right behind, posterior to the nasal cavity, right behind there. And anyone who has had a liquid entering to their nasal cavity knows that we don't want that to happen. So that's why the uvula and soft palate seal off the nasal cavity when we swallow something. Well, then behind the oral cavity, posterior to that, at the right part there is going to be our oropharynx. And finally, the most inferior part of the pharynx, our laryngopharynx. Let's have a look of the larynx, so our voice box, if you wish to describe it with layman's terms. You'll see there's a lot of cartilage there, and these cartilage structures are often the ones that students easily learn about these, but I do want to remind you that there's also soft tissues, muscles, all sorts of other things going on there, but these cartilages are definitely good anatomical parts for us to learn. And we're going to cover all of these cartilages. I do want to show that I've drawn this diagrammatic view of our larynx, that they are a little bit in a different scale on the right and left side. So on the left of the screen, you see it as we were looking it straight from the front. And on the right-hand side, you'll see it as a cross-section. It's a little smaller, but I hope you can forgive me for that. So the biggest part of our larynx is made with the thyroid cartilage. Thyroid cartilage is one single cartilage piece, large, dominant there, and there's certain parts that often are very visible for us. So exteriorly on the superficial anatomy, you can see the laryngeal prominence, so Adam's apple in layman's terms. There's also our thyroid gland would be located at this area. So this is why knowing the basic anatomy is going to be so important for us. At the inferior part, cricoid cartilage forms a solid circle, closes off, and it's only cartilage that forms a full enclosed circle there for our larynx. And again, on some of the passengers, or some of the customers, or some of them, sorry, patients, you can see the cricoid cartilage as external anatomy feature there as well. Right inside, you can see epiglottis, which forms the flap that seals off the lungs and trachea while you're swallowing, so we don't get any liquids, any foods going in there. And here you can see a nice picture with extremely long epiglottis. So this is an unusual one, and it extends all the way to the oral cavity, so you can see it nicely there peeking out. This would not normally be the case. Final structures that I want to show you. We have two arytenoids, one on both each side, so left and right. These, if you wish to describe them, are a little bit pyramid shaped, so triangular shape. And the reason why they're going to be important for us is that this is where the vocal cords are connected. So set of muscles controls the arytenoid cartilages, and through that we're able to control how tight or relaxed the vocal cords are. And this is the basis for us to generate the sound of the speech, for example. At the very top, superior to the arytenoids, we have our corniculated cartilages, tiny little tips on the top of there. And then we have final structure, two cuneiform cartilages, which are actually embedded into the soft tissue wall of the larynx. So we rarely see those unless we dissect into this structure. So that covers our larynx. I do want to show a couple of functions that we have highlighted here for your larynx. So of course, it's controlling the airway to the lungs, separating the roots for the air and food, and definitely the voice production. So in layman's terms, voice box, so that's going to be an important structure for us. In terms of the vocal cords, I have highlighted a couple of things here. So remember that vocal cords are actually made of elastic fiber. There's no blood vessels going there, and this is why the vocal cords actually appear white when you look at down the throat and study them. I do want to highlight the term glottis. So this is the space between the vocal cords, and by manipulating the opening of the glottis, we're able to produce the sound. Some prefer to call it rima glottis, so don't be surprised if you see those two terms being used interchangeably. Finally, I do want to show you that we actually have two sets of vocal cords. More superiorly, vestibular folds, which are our false vocal cords. They're not involved with the voice production as such. And then more inferiorly are vocal ligaments, which are actually the vocal cords that vibrate from their edges and generate the sound. Of course, I wanted to show here that we remember that the voice is further manipulated further down the tract as we pass upwards superiorly. I included a little story about didgeridoo, which is an Australian native instrument. You can watch the lecture video if you're interested on that. And I do want to highlight quickly tracheotomy. So when you have to make an incision to the neck just below our large cartilages, so we're able to provide air pathway if there's a blockage more superiorly that prevents the air from passing. You can study more about that on the lecture video as well. Let's say a couple of words about trachea. Trachea about 4 inches long, about 3/4 of a diameter inches of a diameter, runs from larynx to the mediastinum. Very flexible, and the flexibility and structure is maintained by having these cartilage rings, which are actually a cricoid cartilage. The cricoid cartilage is the only full ring, and then when you move inferiorly, you'll find only C-shaped rings, and we'll discuss why do they appear as C-shaped. So you'll notice the trachea is more anterior to the esophagus, and in case you have something large that you need to swallow down your esophagus, it's able to extend a little bit to the your respiratory tree by this fact that it's open from the very back. Once you reach the very bottom of your trachea, it divides into two primary bronchi at the location that's called carina. That's going to be an important anatomical landmark if you end up working on this field, and something to bear in mind. What I want to show you, what often students don't know, is that we have actually a lot of these microvilli, little hair-like structures covering the entire trachea. So they're responsible for wiping upwards anything that has entered to the respiratory tree that shouldn't be there. So any dirt travels to your throat, and then you just swallow it down. So it's automatically keeping itself clean. A quick note about the angles of the primary bronchi. So the right primary bronchi comes down in a steeper angle, and that's why a lot of the time foreign objects that, for example, kids end up breathing in, we end up finding them on the right lung. I also wanted to teach you a term called hilum. Hilum is the location where the primary bronchi actually protrude into the lungs. So something that we will use later on and you want to be familiar with. And then if you look, the primary bronchi separate further to secondary bronchi and so onwards until we get to the very end of our respiratory tree. A couple of words about the lungs. We talked about apex when we talked about the heart, and I mentioned that it's the sharp point of an organ. Well, in this case, the sharp point of a lung is going to be most superior part, not inferior as in the case of the heart. Base is going to be resting on your diaphragm. And I also wanted to point out, look how far down the lungs continue laterally. This is often a surprise when we start doing dissections, both for the students and also medical professionals. And the word hilum we already covered. In terms of the lungs, in general, on the right lung, which is larger, we have 3 lobes. So we have our superior, middle, and inferior lobe. And then on the left lung, only 2 lobes, so superior and inferior. The reason why left lung is so much smaller is that the heart was resting on the left side of the mediastinum, so some of that space is taken by the heart, and that's why we don't see as many structures on the left lung. Well, we also have fissures that separate these lobes, so on the right side, horizontal more superiorly and more inferiorly oblique. On the left side, we only have the oblique one. Notice the cardiac notch, that's the indention on the left lung that takes the space of the heart. Where lungs are enclosed in a pleural cavity, so double membrane cavity, we have more inner visceral pleura and more outer the parietal pleura, and in between them we have a fluid-filled sac. And as you remember from the pericardial cavity of the heart, this allows us to do many different things. Lubrication is the same as with the heart. Cushioning goes the same as with the heart, but this is a new concept for us. This pleural cavity generates actually a negative pressure around the lungs, which is the force that actually keeps the lungs expanded. So what you might notice if you study the respiratory tree is that the amount of cartilage decreases as you go further down, smooth muscle increases. Let's have a look at the alveoli very quickly. Alveoli are these small sacs of very end of the respiratory tree where the gas exchange happens. There's about 300 million of those in a individual, and they form the most of the lung volume. This is how we're able to pack a lot of volume in a relatively small space. They are also richly supplied by the cardiovascular system, so a lot of capillaries, very close connection to these alveoli, so gas exchange is super easy and efficient there. And then a couple of words before we wrap up regarding the physiology. There's 4 phases of respiration. And let's go through those using the diagram that I prepared there for you on the right side of the screen. So pulmonary ventilation is the stage where you simply get the air from outside the body to the lungs to the very end of our alveoli. Within the alveoli, we have external gas exchange, which gives us a clue that we're going to see the gas exchange happening somewhere else as well. So this is when we are taking oxygen to the capillaries and putting out carbon dioxide to the alveoli. And this all exchange is driven by the difference in partial pressures, and we'll have a look at that concept a little later. Well, remember that we have to transport these gases. This is where our capillary network then changed into venules and veins and again on arteries and arterioles. We move from pulmonary system to the systemic circuit, and once we reach our tissues or interstitial fluid, it's the internal gas exchange that's responsible for giving up the oxygen to the tissues or interstitial fluid and picking up carbon dioxide, which then gets transported to the lungs. Do notice that this is a two-way system, so of course we take materials away from the tissues to the lungs as well. I mentioned about the negative pressure within the pleural cavity. If you have a puncture for this pleural cavity, what you'll end up noticing is that the lung will collapse. And this is why maintaining this negative pressure is going to be important as a first aid as well. You try to limit the escape of the gases from there. A couple of words, inspiration and expiration. So breathing in, breathing out. Which one do you think requires energy? Which one doesn't? Well, we'll notice that inspiration is an active process, whereas expiration happens passively as your cartilages, bones, and muscles return to their resting state. So to breathe in, you have to recruit certain muscles, and these are going to be our external intercostal muscles. So the muscles between the ribs, the external layer of those, but the most important respiratory muscle is going to be our diaphragm. So while you're breathing in, it loses its dome-shaped shape and goes downwards, and this increases the space of the lungs, thoracic cavity, and air flows in. Expiration, like I said, happened passively. However, you can do forced expiration where you recruit muscles such as oblique abdominal and transverse abdominal muscles, and also the internal intercostal muscles to really force air out of your lungs. I mentioned a lot of non-respiratory air movements that we have going on. So everything from coughing, sneezing, crying, laughing, hiccups, and yawning. So not everything is related to just breathing. Two terms that I want you to know. Surfactant is a lipid protein complex that reduces the surface tension and actually prevents the alveoli from collapsing, whereas compliance, that's a little bit of a harder definition to get your head around. So how I would simplify is consider it as a measure of stretch that the lung has, and a great compliance high number means that we have a lot of stretch. How you assess ventilation, simple machine, it's called spirometer. You find more sophisticated electronical versions where we're able to also measure the gas movement of both ways, so breathing in and breathing out, whereas the traditional spirometer is only going to be breathing out. So based on this, we can measure respiratory volumes, which then allow us to calculate respiratory capacities. And let's have a look of those. Here's a trace of an individual who's been breathing normally, then doing a maximum breath out, maximum breath in, and we're having a look of what those traces look like. I think these values would be appropriate for an adult male. So the amount of air that moves normally in and out during normal breathing is going to be our tidal volume. The amount of air that we can breathe in forcibly beyond the normal tidal volume is going to be our inspiratory reserve volume. And the opposite for that, the amount of air that we can forcibly expel is going to be our expiratory reserve volume. Any amount of air that actually doesn't leave the lungs and remains in the lungs and the respiratory pathway there is going to be a residual volume. Well, using these, you're able to calculate these capacities. So inspiratory capacity is your normal breathing plus the extra that we can breathe in. Your functional residual capacity is your residual volume plus ERV. Vital capacity, TV, IRV, and ERV added together, and then adding all of these together gives us our total lung capacity. There's going to be dead space, and dead space refers to the air that remains in the passageways. That would be our anatomical dead space, and alveolar dead space refers to the space that's occupied by non-functional or collapsed alveoli. So something where the gas exchange doesn't happen. So the total dead space would be adding these two together. I mentioned that the gas exchange happened both between the lungs and the blood and between the blood and the tissues. So both within our external and internal respiration. And the gas exchange is due to partial pressures and understanding the concept of partial pressures would demand us to spend probably next 4 hours talking of that. So I'm just gonna mention at this point that we just accept for our course that partial pressures exist, and they're typically measured as millimeters of mercury. So what you'll notice that there's a partial pressure difference between the oxygen and carbon dioxide and in the capillary, and oxygen and carbon dioxide in the alveolus. And this is what drives the exchange of these gases. You remember we always move from high to low concentration until they're balanced. So the blood that leaves the lungs is gonna be similar amount of partial pressure for oxygen and carbon dioxide as we have within the alveoli of the lung. And same goes the other way around, again from high pressure to low pressure at the internal gas exchange when we're exchanging the gases from the cardiovascular system to the tissues or to the interstitial fluid. Well, how do we transport most of the oxygen? That's bound to the hemoglobin, as you remember from our discussion of the blood, about 2% bound to the plasma. How about carbon dioxide? About 75% as a bicarbonate, 15% as a hemoglobin, and 10% as plasma. And this brings us to the very last concept, which is something that you can cover through the lecture video. You'll notice that we'll see again our familiar equation of the cellular respiration, how sugar and oxygen are used to produce energy at the mitochondria. As a waste over product, we are left with carbon dioxide and water, which then help us to formulate our carbonic acid equation. So to get rid of the carbon dioxide and oxygen, we end up producing bicarbonate and hydrogen ions. Bicarbs we can breathe out, hydrogen ions we urinate out. So this really explains all of these systems that we're going to cover for the rest of the semester. And really, that's the summary of this lecture. The final concept that you can have a look of is the fact that there's going to be less oxygen at the higher altitude than at the sea level. And this, of course, causes your body to respond to that. You start to produce more red blood cells, more hemoglobin. So athletes go often to the high altitude training. So theoretically, when they return back to the normal altitude, they're able to outperform their peers because they're able to carry more oxygen. Of course, we have groups of individuals who are used to living at the high altitudes. Individuals who are not used to that might get altitude sickness. And on our lecture about endocrine system, we talked about the hormone EPO that can be used to generate the red blood cell and hemoglobin production at the higher rate as you would do in a higher altitude. Using that is, of course, not allowed in a sports setting. Respiratory rhythm regulated from the medulla and pons, and normal respiratory range somewhere between 12 and then 20 breaths per minute. It is faster with the newborns and cats. So you remember that I always ask about the cats in your exam. So something to bear in mind. When you look at newborn, don't get freaked out if they breathe faster. final concept that I wanted to introduce you is hyperventilation. So if we have too much carbon dioxide, um, it removed from the body. So, for example, anxiety attacks are often associated with that, and you actually end up getting rid of too much carbon dioxide, which can then cause a lot of issues like cerebral vasoconstriction, ischemia, dizziness, fainting. Early symptoms are simply tingling and involuntary muscle spasms, but this can become quite serious. So the traditional treatment for that was to give the patient a paper bag and tell them to breathe in there, with the logic that some of the carbon dioxide gets trapped in there and gets breathed back in as they keep breathing. So that concludes our review of the respiratory system. And let's just jump back in to our review session slides. And just to wrap up, I want to remind us that I'm happy to accept any late work, any missing assignments. Just message me directly on Canvas with specific details, which assignments those are. I know that I have quite a few messages there waiting for me to review and implement, so bear with me as I'll get to those. And finally, you can get tutoring through the college via Cranium Cafe during this COVID time when everything is done virtually, but I'm also happy to facilitate one-on-one or group sessions. Just message me and we'll find a mutually agreeable time. And at this point, I would normally ask for any questions, but as we know, our bandwidth is limited, so I'll leave those to the next week, or alternatively, you can message those to me. And I think that concludes all of the objectives that we had for this session. So I hope it has been helpful. And like I said, we won't have our normal Wednesday session, unfortunately, but I will see you next week. I know that there's questions about the exam and so on. Those I will address either via Canvas messages or then next week. So again, as with the previous practical, wait until you get your regraded grade. The automatic computer system grades those rather harshly. So that's it for this session. Thank you for joining me. I hope you have a very good rest of the evening.